It's a great honor to contribute to your meeting. I feel very honored and I'm delighted to make a contribution. So in the next 25 minutes, I will talk about pharmacological options for acute kidney injury. These are my disclosures, and they have not influenced what I'm going to say. So acute kidney injury is clearly very common. In hospitalized patients, it affects more than 10%, and in the intensive care unit, more than 50% of patients develop acute kidney injury. And here are the most common causes, and I'm sure they will be all familiar to you. So sepsis, post-surgery, and drugs are the most common reasons for acute kidney injury. But obviously, in the majority of patients, acute kidney injury is multifactorial and not just due to one etiology. So it's a common complication, and at the same time, at the moment, we have no specific drugs for this condition. And I could stop my talk here because we do, at the moment, don't have any drugs. But I hope I can convince you that I am hopeful there will be changes in the future, and I'm hopeful as our understanding of acute kidney injury improves, we will also identify targets for drugs, and we will hopefully get closer to drugs for specific types of acute kidney injury. And I'm saying this because we have a much better understanding of acute kidney injury now. We know that different types of acute kidney injury are never the same. Now, before I talk about the potential pharmacological targets, I'd just like to remind everybody why the kidneys are so vulnerable. So in health, as you all know, the kidneys receive about 20% of our cardiac output. The kidneys are predominantly consisting of blood vessels, some tubular structures, and some cells in between. Now, the kidneys receive a lot of blood in health. In critical illness, they sometimes receive less and sometimes even more. In some situations, perfusion of the kidneys is even improved. The majority of blood within the kidney is in the outer, in the cortex, and within the medulla, there's far less blood. And importantly, the blood within the medulla in health is very close to hypoxic conditions. Now, the tubules and the tubular cells are obviously the cells that are amongst the highest metabolically active cells in the body, because they continuously reabsorb water and electrolytes, in particular sodium. And it's quite remarkable. They can do this despite, as you can see here, close to hypoxic conditions. And they can do this, the tubular cells can do this because they're surrounded by blood vessels. And I'm putting up this slide to illustrate that the microcirculation is crucial to kidney function. And any disturbance of this very well-organized microcirculation affects the tubular function and affects kidney function. And that brings me immediately to conditions like sepsis, where, as you all know, in sepsis, we have severe endothelial dysfunction with interruption of the vessel wall, with endothelial cell swelling, and with an increase in permeability. Furthermore, in sepsis and in many other inflammatory conditions, the normal blood flow is affected. And so in these conditions, sepsis is the most common one, but also post-cardiac surgery, for instance, there will be impaired microcirculation, there will be the formation of microthrombi, there will be changes in vascular tone, and there will be changes in vascular permeability. And all of this affects clearly the blood vessels in the body, but it does affect all the peritubular microcirculation as well. And if microcirculation within the tubules, within the kidneys, in the peritubular vessels is affected, ultimately the tubular cells will be damaged and come to harm. It's not only microcirculatory dysfunction, which is a problem in a lot of conditions in critical illness. There will also be changes in vascular tone. And that's important for the kidneys because glomerular function depends on the pressure gradient between the afferent and the efferent artery. And this may be altered in inflammation, in particular in sepsis. And if this changes, then immediately the pressure gradient changes and the glomerular filtration will change. Furthermore, we know that in certain conditions, and again, sepsis, the most common one, shunts open up. So pre-existing shunts, as shown here. And if this happens, so either changes in vascular tone or opening of pre-existing shunts, then you can see here how this affects glomerular filtration. And the kidneys will produce less urine, so less glomerular filtrate, less urine. In conditions associated with cytokines, again, the tubular cells are at high risk of being damaged. And that's because these cytokines and other sometimes pathological mediators, they're all tiny molecules, so they get filtered by the glomerular filtration. And they can damage the tubular cells from within the tubule. So if you imagine you're a tubular cell, then it's really quite hard because there is damage from within the tubule with some damaging cytokines and pathological peptides and mediators. And at the same time, the peritubular microcirculation may be impaired, and there may be significantly reduced blood supply. There may also be damage of the tubular cells as a result of microthrombi and increased endothelial permeability, increasing the distance between the tubular cells and the microcirculation. And then there may also be, as I've already said, actually complete seizing of glomerular filtration as a result of opening of the shunts. So multiple pathways contributing to acute kidney injury. We now know that acute kidney injury is an inflammatory condition. So two things happen. Firstly, the kidneys are obviously at the receiving end of the blood. And in a lot of conditions, there will be inflamed cells, a lot of leukocytes and other inflammatory cells, and they will get into the kidney. And then secondly, there will be damage to the tubular cells as a result of this nephrotoxic insult. And both together lead to further activation of cells within the kidney and the generation of inflammatory cytokines. So the kidney itself can then lead to additional inflammatory pathways and may lead to the release of cytokines, which then cause problems in other organs. We now know that the mitochondria get affected in acute kidney injury, and mitochondrial dysfunction contributes to acute kidney injury. So the tubular cells are amongst the highest metabolically active cells. So they depend on working mitochondria. And normally, there's a good balance between fusion and fission, as shown here on the left. But in following some nephrotoxic insult, whether it's sepsis or whether it's drugs or other nephrotoxic triggers, there's a shift more towards fission. So the mitochondria split into tiny little mitochondria, and they are less efficient. And as a result of this, the cells produce less energy, and various important pathways within the mitochondria are inhibited and impaired. And if severe, this can lead to cell apoptosis and even necrosis. And the cells try to save themselves and protect themselves by simply shutting down and down-regulating their energy processes. They also trigger cell cycle arrest just to stop being damaged from the nephrotoxic trigger. And lastly, depending on the nephrotoxic insult, there may be additional factors that contribute to acute kidney injury. So for instance, there may be additional, in sepsis, there may be additional insult from the drugs we've given. We may have given aminoglycosides and they are, we know, tubulotoxic, or we may have given tubulotoxic, or we may have given acyclovir, which we know causes intratubular crystal formation and obstruction. Or we may, as Professor Malbrain elegantly showed, have overloaded the patient, and there may now be a very high pressure within the renal vein causing intrarenal congestion. And we may be dealing with somebody who actually has very poor renal reserve and is even more susceptible. And this is the problem. That's why it's so difficult to for us to find specific therapies for acute kidney injury, because ultimately there are so many different pathways that may contribute to acute kidney injury, sometimes in isolation, but much more commonly together. Now, it also explains why drug therapies in the past have failed, so drug trials which we've done, because they may not have addressed the right patient with the right specific underlying pathology. But moving forward, it explains our improved understanding now explains why drug companies and also researchers are focusing on particular pathways and are testing different drugs. So as you can see here, I said that acute kidney injury is an inflammatory condition, so it does make sense to look at anti-inflammatory drugs. I also explained that there is mitochondrial dysfunction which contributes to acute kidney injury, so it does make sense to explore drugs that improve mitochondrial function. Now, the microcirculation is so important for the kidneys. Impairment of microcirculation contributes to acute kidney injury. And again, it explains why certain studies look at drugs that affect the hemodynamics with the intention to improve intrarenal microcirculation. Now, the fact is, at the moment, we don't have any drugs for acute kidney injury, but these are the drugs that are currently being investigated. And just another way of illustrating this, here you have, again, the same drugs as I showed you previously, and just to show you where they may or try to target acute kidney injury. So we have certain drugs that look at improving glomerular filtration by changing the vascular tone of the afferent and the efferent branch. We have certain drugs that focus on mitochondrial function with the aim to improve the health of tubular cells. We have drugs that look particularly at inflammation and dampening inflammation. And then there are also drugs or therapies that aim to help kidneys recovering faster so that kidneys don't stop progressing to severe acute kidney injury. But the whole field is quite complicated because, as I've already said, many conditions are, in many patients, acute kidney injury is caused by more than just one pathology. Furthermore, patients are often at different phases of acute kidney injury. And that's why drug trials have focused on particular types of acute kidney injury, as shown here. And other drug trials have focused on different phases of acute kidney injury, some to prevent acute kidney injury in high-risk patients and others to prevent progression after acute kidney injury has already occurred. And you can imagine that the wrong drug at the wrong phase in the wrong patient who doesn't have the underlying pathology is likely to be unsuccessful. And I just give you a few examples of therapies that have been investigated or are being investigated at the moment where we are waiting the results. So there are drug trials that focus on medications, on vasopressors or vasodilator. And the idea here is that we know the glomerular filtration depends on the pressure gradient between the afferent and the efferent branch. And if you give a drug that is vasoconstrictive, but acts predominantly on the afferent branch, it will have a different effect compared to a similar vasoconstrictor with a target which targets the efferent branch. And that's important because all the existing vasopressors, which we currently use in clinical practice, act differently on the blood vessels within the kidney. And it is completely logical that individual researchers and studies are now looking into this more and are studying these different vasopressors. Just as an example, so angiotensin 2 is a vasoconstrictor. It acts predominantly on the efferent branch of the glomerular vessels. So it can increase glomerular filtration by increasing the pressure gradient. And if you look at a sub-analysis of the ATHOS trial, which was a randomized controlled trial comparing angiotensin versus placebo in patients who were already on noradrenaline, when they analyzed the group of patients who were on renal replacement therapy at the time of randomization, then they showed that the patients who were randomized to angiotensin 2, here in the continuous line, came off renal replacement therapy much faster. And physiologically, this makes sense because angiotensin increases glomerular filtration. Now, this is a sub-analysis, and clearly it needs to be repeated, but it's an example to demonstrate that we need to learn more about these different vasopressors, and they have to be tested in patients with acute kidney injury so that we give the right vasopressor to the right person and avoid it in patients who may come to harm from particular vasopressors. And another example is alkaline phosphatase. So alkaline phosphatase is obviously an enzyme, which we all have. We have different forms of alkaline phosphatase in our body. And we know that alkaline phosphatase has an anti-inflammatory property. So this is the normal situation is that in sepsis, endotoxin, or also called lipopolysaccharide, it binds to toll-like receptor 4. And after binding to this receptor, various cytokines are released and they are responsible for all the clinical features of sepsis, so vasodilation, fever, hypotension. It's become clear that alkaline phosphatase is there to dephosphorylate endotoxin or lipopolysaccharide. So it removes one phosphate molecule. And by doing that, the endotoxin is no longer as pathogenic as before. So it still binds to the receptor, but it cannot trigger the cytokine release. And that's well known. We also know that alkaline phosphatase not only removes phosphate from endotoxin, but also acts on adenosine, and it acts on various inflammatory mediators. So it has anti-inflammatory properties. So it was tested in patients with sepsis-associated acute kidney injury in the STOP AKI trial. And the hypothesis was that this medication, or this enzyme, may help patients recover faster from acute kidney injury because it would reduce the damaging effect of sepsis and be anti-inflammatory. The trial was conducted a few years ago in patients who had sepsis and had acute kidney injury. And as you can see here, the primary endpoint, primary outcome was renal function at 7 days. So in the patients who received alkaline phosphatase, indeed, at 7 days, they had a better kidney function as measured by the creatinine clearance. But this difference was statistically not significant, and therefore it was a negative trial. It was concluded that alkaline phosphatase did not have improved renal recovery from sepsis-associated AKI. However, when they went further and looked at kidney function at 28 days, there was a significant difference. And furthermore, there was also a difference in mortality. So patients who had received this enzyme had better kidney function at 28 days and had a lower risk of mortality. And this is what prompted the investigators to do the revival trial, which essentially looks at the whole issue once more again, but has a different primary outcome. And the results of this trial are currently awaited. And we're all waiting to hear whether it could be a medication for patients with AKI. Similar to the previous Stop AKI trial, they looked at patients with sepsis, requiring vasopressor support, and having AKI. And the results will hopefully be available this year. Another exciting drug is nicotinamide. Nicotinamide is a coenzyme which we all need. It has an important role in numerous processes, including important processes within the kidney. And we know that chronic nicotinamide deficiency is harmful to kidney function. And there are currently various trials exploring the role of nicotinamide in patients with acute kidney injury. Now, important to make sure that nicotinamide is administered at the right time. The trials are being conducted in patients where you will have better idea of timing. So in this case, for instance, acute kidney injury after cardiac surgery, we can say exactly when the insult occurred. Lastly, I want to just mention mesenchymal stem cells, because there's been a lot of excitement about mesenchymal stem cells. They are known to help kidneys cells recovering. They are known to dampen the effects of inflammatory mediators. And there was a lot of excitement and hope that they could help and prevent acute kidney injury after cardiac surgery. Unfortunately, the first double-blind randomized controlled trial looking at mesenchymal stem cells in patients who had undergone cardiac surgery was negative. But there are some ongoing trials looking at mesenchymal stem cells to protect the kidneys and to protect kidney function. Again, as shown here, mainly in cardiac surgery, different trials looking at different forms of stem cells. And again, the results are awaited. And this brings me to the end. At the moment, we do not have a drug for acute kidney injury. But as our knowledge of about acute kidney injury improves, and we have a much better understanding of the different types of acute kidney injury, I am hopeful that we will then also find certain therapies for particular types of acute kidney injury. But we've clearly now understood that it will not be possible to find one drug for every type of acute kidney injury. So we need to learn how to subphenotype AKI and then test particular drugs which address the underlying pathology. And that'll be the only way to make progress. So in conclusion, I do believe we will move forward. Our understanding about the pathophysiology of acute kidney injury has given us a much better understanding of targets for future drug development. And drug development needs to go hand in hand with our attempts to subphenotype acute kidney injury better. Thank you very much for your attention. It's been an honor to contribute.